Good evening to everyone. First of all, I would like to thank everybody for coming in. This is a very important topic and a topic that is close to our heart, both at Madhvi Netralaya and District Punjabi Hospital. Tiwari sir was the pioneer of ROP screening in Bihar. He was the first person to go into periphery and start doing it. And then the same thing I inculcated when I was in his hospital. And the passion for ROP screening came from him. This is a very important topic because this has a lifelong impact on a child that doesn't know that he is having that problem or he can have that problem. An unsuspecting child becomes blind for life just because he or she was not referred or was referred but not screened properly and lost the sight. So medical legal aspects aside, it's a very human topic to be considered. And that's why last year we started with this ROP Conclave where we had eminent pediatrician and ophthalmologist coming together to understand what it means to have an ROP screening and how we can inculcate. ROP screening was available in RR before I came in also. It was going on successfully. When I came in, it started at our hospital. Last year we have screened 56 child with ROP, 56 child who were preterm. I think they were more referred to us, but they didn't reach us. So 56 came to us. Out of that, 6 child were having bilateral ROP. The treatment option right now is not available at our hospital, so we referred it to District Punjabi Hospital. I think 2 got operated and 4 got laser and anti-VEGF injection. All 6 child will be seeing for life just because they were sent to us on time and screened properly. So that is why this time also we thought that we have to broaden the horizon. We have to see that more and more people can come in, and that's why we thought to approach BOX, that is Bhojpur Obstetrician Gynecologist Association, and they were kind enough to be a part of this, so that the preterm where it originates at OBS level, so that from there we are now going to start the prevention of ROP, and then the pediatrician can send to us, the parents can be like sensitized at the OBS level, the child can be referred at PEDS level and can be treated by us. So that is the whole agenda that we are going to talk about today. And before start of anything, we have to inaugurate this program. And for inauguration, we are very grateful to have support of IMA. IMA President Dr. Kumar sir is with us. IMA Secretary Dr. Shalini ma'am is with us. And to inaugurate the program along with them is the leading obstetrician from Bhojpur, Vijayalakshmi ma'am, and the senior most ophthalmologist from Bhojpur, Dr. P. Sinha sir. So I would like to call upon all the dignitaries on the dais so that we can inaugurate the program. Opthal is about one theme, Jyot se Jyot Jalao. The sight has to be distributed among all. So everyone will get a candle, and I would request everyone to pass the light to the next person so that everyone can be a part of this inauguration program. Kumar Jitendra, thank you for listening. Dr. P. Sinha sir. Dr. Shalini ma'am.
महाकाय सूर्यकोटि समप्रभ
I would like to request Chief Sir Ma'am, please come and join the inauguration.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
I sincerely bless that this light of this ray of light is spread across all the freedom baby that are being born and prospered thanks to our behavior, and nobody loses their sight to this deadly disease that is ROP. Thank you. With this, I would like to hand over the session to Rakhi ma'am, who will be taking it forward for the off session.
First session is about what role we as an obstetrician has to play in the prevention of retinopathy of prematurity. The whole evening is about retinopathy of prematurity. So we as an obstetrician, what we can do for the society so that deadly disease like a ROP can be prevented in the newborns. So now I would like to call upon Dr. Savita Gupta ma'am for the wonderful presentation. And as the whole RR needs no introduction, madam needs no introduction. So madam, please come on the dais and please give us some insight that what we can do for the society in prevention of retinopathy of prematurity. Now I would like to call upon our esteemed chairperson, Dr. Tanima Singh ma'am. Singh ma'am. Next, our chairperson, Dr. Ranjana Das ma'am. And I'd like to call upon our esteemed panelist, Dr. Barsha Mishra ma'am. I think ma'am is not there. Dr. Sangeeta Gupta ma'am. And Dr. Wonderful discussion. So ma'am, your dice is all yours. So we are waiting to hear from you on your wonderful presentation.
to all. Pranam to all my seniors. I am privileged to be here this evening. Thanks to Shahabad Ophthalmological Society for giving me this opportunity to share my views. The surviving preterm pregnancy, the road ahead. This background history, a very usual case and a real case. We usually see in our day-to-day practice. A close relative of mine at the age of 38 years conceived after IVF treatment. As usual, twin pregnancy, very precious child. Regular antenatal checkup at my clinic. Developed moderate hypertension, that is 176 to 110 millimeter of mercury, tending towards impending eclampsia. Referred to higher center for further management with NICU facility at Patna. On the same day of referral, cesarean section done to prevent eclampsia, one male baby weighing 1.4 kg and one female child weighing 1.8 kg delivered. Both babies are shifted to NICU. The lower weight baby, that is 1.4 kg, was well maintained on incubator, ventilator. Female weighing, that is 1.8 kg, well managed on CPAP. Patient was discharged but residing nearby. Both babies fed on breast milk. After few days, when both babies were out of danger, kangaroo mother care promoted. On day 28, routine screening for ROP done and audiometry also done. On screening, baby weighing 1.4 kg was ROP positive. ROP positive baby was treated by ophthalmologist by laser photocoagulation. Repeat laser done after a week. Now both baby are doing well and they are now 3 months old. We all are happy. Thanks goes to team obstetrician, neonatologist and ophthalmologist. They detected ROP early and saved the baby from blindness. In this case, obviously, the delivery was before term. As we all agree that preterm labor, when uterine contraction occurs with cervical changes before 37 completed weeks, this is termed as preterm labor. If it is before 28 weeks, that is extreme premature. And early preterm are before 34 and late preterm is 34 to 37 weeks of gestation. Preterm labor is a dread for we obstetrician and has great implication on our healthcare system. Major implications are not only medical, but there are many factors like social, emotional, economic, and overall the healthcare system of our country. With advancement in science, preterm labor should decline, but all over the world there is an increasing trend towards preterm labor. Overall, 15 million preterm births occurs every year throughout the world, and out of them 1 million die due to prematurity. Unfortunately, our country Bharat is leading the list. Almost 35 lakh preterm birth occurs in a year, and more than 3 lakh babies die due to prematurity. There is a great financial burden on parents and as well as on our country itself. Survival rate of preterm baby is improving with advancement in neonatal intensive care system in metros and mega cities of India as well. In this slide, we can clearly see that at 27 weeks of gestation, it is around 70%. But at 28 weeks, it bounces up to 90%. But up to 30 weeks, infants are very, very premature, and there is high chances of long-term disabilities in these premature babies. Baby born preterm, they have high mortality rate, and those who survive have a great risk of neurological impairment. Cerebral palsy, visual and hearing disorders, cognitive dysfunction, psychiatric disorder in adulthood, early short-term complications like preterm mortality, respiratory distress syndrome, hypothermia, hypoglycemia and infection are all well handled at tertiary care center. But long-term complications like intraventricular hemorrhage and white matter injuries leading to cerebral palsy and ROP, retinopathy of prematurity leading to blindness, hearing disorder, necrotizing enterocolitis, cognitive disorders. Long-term complications are only apparent after the baby is discharged from hospital, and most common is cerebral palsy. Cerebral palsy rate at 30 weeks is 6 to 8%, but as gestation goes down, it bounces up to 30%. The second most common long-term complication is ROP, retinopathy of prematurity. What is ROP? It is vasoproliferative disease of retina. Nature needs 40 completed weeks of gestation to develop a fetus properly inside the protected uterine environment. Retina also takes around 40 completed weeks to mature. Vascularity starts from the center and proceeds towards periphery and takes almost 36 weeks to reach nasal oral serrata. Vision and visual perception depends on retina. Baby, which is developing inside the uterine cavity, suddenly comes out prematurely in the atmospheric environment, and even when the baby is in the artificial incubator, environment is very different from the mother's environment. Mother womb is the best incubator in the world. When baby born preterm, eye gets a signal that time is up, but actually time is not over. So development of retina goes haywire, out of proportion and in an abnormal manner. So there should be no unnecessary haste to deliver the baby preterm. low birth weight babies. Smaller the baby is at birth, higher is the chance of ROP. Less than 2 kg baby weight are more prone to ROP. If these babies gain weight faster, ROP will be less prevalent and severity will also be less. Feeding of preterm babies on expressed milk 2 hourly is the best way to improve weight of the baby and to improve ROP. Kangaroo mother care should be promoted in these babies. Hyperoxygenation and anoxia. It is a very well-known fact that oxygen is required in these preterm babies. If we do not give oxygen, baby will die or become mentally retarded. And if we give uncontrolled oxygen, there are chances of ROP. Hyperoxia causes vasoconstriction leading to hypoxia, and there is excessive and abnormal proliferation of retinal vessels. Oxygen, whenever needed, should be mixed with air, and this is blended oxygen. Pure oxygen is very devastating for eyes. Nursing staff should be trained, and education of these nurses are critical to prevent ROP. If nurses put oxygen around 99 or 100%, chances of ROP will increase. Oxygen supplementation should be monitored cautiously like a dangerous drug. Oxygen supplementation should not go beyond 90% on pulse oximeter reading. Every baby needs a pulse oximeter on their finger so we can monitor how much oxygen they are receiving. Next, very important thing is sepsis. Infection is very prone in our country. Hygiene, hand washing, barrier nursing, not touching the baby too often. No relatives should be allowed to kiss the baby are all preventive measures. These babies have immature immune system. They have high chances of infection, and if we take these preventive measures, ROP will go away. Screen and treat ROP. Otherwise, may cause blindness in both eyes. When to screen? 30 दिन रोशनी के. A baby cannot express that vision is not proper or blurred. The only way to detect is by screening. 30 दिन रोशनी के ठीक उसी तरह जैसे 2 बूंद जिंदगी की. Like 2 drops of polio vaccine will keep legs and arms of a baby healthy. Ophthalmologists say, get your baby retina checked within 30 days of birth. If ROP develops, then the symptoms, when the baby gets symptoms, parents notice this, it is too late. And whom to screen? Less than 2 kg birth weight, less than 34 weeks of gestation, and sometimes at 34 to 36 weeks when there is sepsis and jaundice. Nearly 500 babies per year become blind due to ROP. ROP screening is the best way out. It is a teamwork between ophthalmologist and neonatologist and counseling of parents, where we obstetricians stand to prevent ROP is to prevent preterm birth. If there is no premature delivery, there is no ROP. On the other hand, premature baby die. If baby dies, there is no ROP. Obviously, we don't want this situation. We want every child to survive. In spite of all our efforts, there is an increasing trend towards preterm birth. What are the factors promoting preterm labor? The poor nutrition of the mother. They should gain weight during pregnancy. They should be well fed to carry pregnancy till term. Bharat Sarkar is also taking care of this. There are many national programs like Beti Bachao, Beti Padhao, Janani Suraksha, training of Asha workers, antenatal care programs, iron and folic acid supplementation, midday meals in school. Good antenatal care reduces the risk of ROP to half. Disparity among girls and boys are rampant in our society still. Please feed your girl child well, because she will give birth to your next generation. Early age of marriage and early pregnancy in teenager girls also promotes preterm labor. The legal age of marriage is 18. Pregnant women should not be too immature to hold the baby and should not be too elderly. Medical disorders of pregnancy like hypertension, diabetes are very, very common in these elderly women. And more recent is the test tube baby or IVF baby. They are not only premature, but the triplet and twin are very common. They are preterm as well as low birth weight baby. Prematurity and low birth is the double trouble for these babies. Bharat Sarkar is also concerned about this fact. Upcoming rule is one single embryo should be transferred in each IVF cycle. Other factors are occupational and maternal stress, lack of proper sleep pattern in our youngsters, changes in lifestyle, alcohol and cigarette smoking, infection like STDs, bacterial vaginosis, UTI are the major risk factor for preterm labor. And what are the armamentarium we obstetricians have? We have to suspect, predict, prevent and manage preterm labor so that we give a healthy baby mentally as well as physically to our society. The predictors are past history of previous preterm labor, ultrasound measurement of cervical length and biochemical markers. Strongest predictor is the past history of previous preterm labor. If there is a history of one previous preterm labor, the chances in the next pregnancy is 15%. With history of two previous preterm labor, chances are bouncing, and that is around 30%. The second most important predictor is cervical length. Cervix is a dynamic structure and it shortens as the gestational age advances. Cervical shortening leads to labor. Mean cervical length is 40 millimeter, around 14 weeks of gestation. Short cervical length less than 25 millimeter before 24 weeks is the strong predictor of spontaneous preterm labor. There is no mandate for universal cervical screening, but of course, where there is a history of previous preterm birth and high-risk patient, we should advise these patients to have TVS scan at 16 weeks for cervical length assessment. Few minutes of sonologist matters a lot. TVS measurement of cervical length is very sensitive and ideal. 25 millimeter cervical length is definitely a short cervix. Short cervix before 24 weeks is a strong predictor of preterm labor. Unfortunately, in our country, there is no mandate for universal screening. Some biochemical markers are there. One is fetal fibronectin. It is a good predictor for preterm labor. How we can prevent preterm labor? There are many drugs which we are using. Progesterone therapy, corticosteroids, tocolytics, and magnesium sulfate for neuroprotection. We are using progesterone since long in women with short cervix and with history of previous preterm birth. Progesterone reduces the risk of spontaneous preterm delivery. There is a great debate for dose and route of administration of progesterone, natural versus artificial progesterone, but there is no debate regarding its therapeutic use. Debate of the century is cervical surplus versus progesterone. NICE recommends both surplus as well as progesterone. When there is previous preterm birth and cervical length is less than 25, surplus is applied with progesterone. We apply McDonald's stitch with progesterone. There is a great success in preventing preterm labor. Antenatal corticosteroids, they are panacea in management of preterm labor. Bharat Sarkar also recommends use of antenatal corticosteroid. So much so that ANMs are getting trained for the use of corticosteroid in preterm labor. Neonatologist also recommends the use of corticosteroid for lung maturity. I am very sure that most of obstetricians are using corticosteroid for lung maturity. Personally, I am using it for last 30 years. Antenatal corticosteroid doesn't increase the risk of maternal morbidity and mortality. Antenatal corticosteroids will reduce neonatal death, respiratory distress syndrome, less respiratory support is needed by the fetus, and NICU admission is also less. Indicated in all women at high risk of preterm delivery between 24 and 34 weeks of gestation. For women going planned cesarean between 37 and 39 weeks, it should be given prior to cesarean section. Antenatal corticosteroid reduces neonatal mortality and morbidity when the first dose is given 48 hours prior to birth. There are two medicines, dexamethasone and betamethasone. They are easily available in our country. Dexamethasone is WHO approved drug, is very inexpensive One vial cost only 10 rupees and widely available in our country. Betamethasone, equally good, but the salt betamethasone acetate phosphate is not available in our country. That is the long-acting one, and thus dexamethasone is more appropriate and recommended by WHO. Dexona, we all know about Dexona. Dexona is available in 4 milligram strength. We need 6 milligram 12 hourly. Only 4 doses are required. So we get the neonatal lungs to be mature. The role of tocolytic. There are so many tocolytics with us. We all agree about the role of tocolytics. Tocolytics slows down, inhibit contraction of uterus, thereby can help in arresting premature labor. Now, the role of tocolysis is very limited. It is the primary aim of tocolysis is to buy time for admission of complete antepartum dose of antenatal corticosteroids to reduce respiratory distress syndrome, and second is to facilitate in utero transfer of fetus to tertiary care center where NICU facility is available. Now comes the role of magnesium sulfate, a game changer as a neuroprotector. We are using magnesium sulfate since long in hypertensive disorder of pregnancy and in eclampsia, tocolysis for preterm labor, but now the role is coming for fetal neuroprotection. As we all know that magnesium sulfate is an anticonvulsant drug. It prevents blood pressure fluctuation. Meta-analysis concluded that MgSO4 for neural protection decreases the risk of childhood cerebral palsy. It is safe and very safe drug to be used for neuroprotection. We obstetricians are very much worried about the dose of magnesium sulfate regarding cardiac and respiratory arrest. No. It seldom occurs. We have wrong fear. It is less used by us even for pre-eclampsia and eclampsia all over the country. And the dose is 4 gram IV loading dose in 100 ml saline over 30 minutes, preferably 4 hours prior to preterm birth, and maintenance dose is 1 gram per hour. WHO strongly recommends the use of magnesium sulfate. There is a study in Western India. They came to a conclusion: those babies who are exposed to magnesium sulfate require less respiratory support, and so there is no need of excessive oxygenation, and there is prevention of retinopathy in this baby. MgSO4, which is safe drug, we should use it for neuroprotection as well as for prevention of ROP. A book is published, The Legal Rights of Unborn. Retinopathy of prematurity not only opened the eyes of an ophthalmologist and neonatologist, and now the turn is of the obstetrician. Why I am emphasizing all these things? Rampant medico-legal cases are filed against doctors all across the world, of which many are for missing ROPs. Rupees 1.4 crore compensation slapped on doctors for missing retinopathy of prematurity in one case. So we have to be very careful in handling these preterm babies. We have to save ourselves from medical legal issues. Counseling of mothers and relatives should be done properly. Verbally as well as written documents should be there, and timely referral to higher centers with NICU facility should be done. Timely screening for ROP. Thank you. Thank you very much.
Which we can take from ma'am's presentation. There are three magic words. First is prediction of preterm labor, prevention of preterm labor, and management of preterm labor. So prediction is mainly by the ultrasound screening of cervical length, and the most important predictor, as ma'am said already, is the previous history of preterm birth. Now coming to the prevention, how we can prevent, that is the most important thing. If we can prevent preterm labor, we can prevent ROP also. So for prevention, we as obstetrician, we are already giving progesterone and we are already doing cervical cerclage. So these are the two main things by which we can prevent preterm labor. And for the management part of preterm labor, there are three things: steroid, tocolysis and magnesium sulfate. So steroid, I think everybody is using for a long time, and if we are using betamethasone, till now we can convert it to dexamethasone. It needs 4 doses, 12 hours apart. And regarding the tocolysis is only for buying time. Only for 24 to 48 hours we can give, only to buy time so that the steroids can act and we can transfer the neonate in utero to a better facility where the NICU facilities are better. It's always better to transfer the neonate in utero rather than after delivery transferring the neonate. The survival rate is much less. So if we don't have a facility for the neonate at our center, we should always transfer the neonate in utero to a better facility where the NICU facilities are present. And the third thing, magnesium sulfate, which I think we have not started using till now, but it's high time that we should start. So what was recommended is less than 30 weeks. If we are planning for a delivery, then we should give magnesium sulfate for neuroprotection, and it should be continued for 24 hours. So the first loading dose is 4 gram loading dose followed by 1 gram per hour infusion. And ma'am, just one question, like if we are planning for a cervical cerclage, if a patient is having a previous history of preterm birth, then when we should tell our sonologist to screen for the cervical length? At what gestation?
It should be done at 14 to 16 weeks of gestation, and just write cervical length assessment. It is 40 millimeter till 24 weeks. After that it goes down. So we preferably do at 14 to 16 weeks, and cervical cerclage should be given at 16 weeks.
So I think when we are when we are suggesting the patient to go for an NT scan around 11 to 14 weeks, at that time we can ask the sonologist to spare some more time and tell us the cervical length. That can be very helpful in predicting of preterm birth. So that is one take-home message, that please ask for a cervical length to the sonologist when you are requesting a NT scan. So that is a very important take-home message. And regarding progesterone, ma'am, like when we should start progesterone, at what weeks of gestation, and till what week of gestation we should continue?
We can continue from 16 weeks onward, or what previous history suggests us. Like in previous pregnancy, the preterm birth is around like 20-24. We should start it at 16 weeks and we can go till 36 weeks. It is a very safe drug, and it is a natural hormone which is secreted by the body and to continue pregnancy.
And what is the role of SCG in the injection in prevention of preterm labor? Like before
SCG should not be used after 4 months, because it is when placenta takes over the work, then it is not needed. Only progesterone will be efficient.
So before 16 weeks we can give LCG injection weekly, and after that we can continue progesterone. So there is a lot of controversy regarding progesterone. Many studies are there, promise trial, and many trials are there suggesting that there is not much role of progesterone. But what I have personally felt, and practically there is no harm in giving progesterone. So for the mental satisfaction of both the obstetrician and the patient should also feel that we have been giving something, and obstetrician also there is a mental satisfaction that we are giving something extra. So there is no harm in giving progesterone. It acts as an immunomodulator. So we can safely give progesterone for prevention of preterm labor. So I think that was a wonderful session, ma'am. Thank you, ma'am.
Like you have said, there is very limited role of prophylactics in preterm. But if we need, what are the drugs which is most?
Previously, we are using beta mimetics. Beta mimetics, Duvadelan, everyone knows about it, and it is very safe. But beta mimetics have some side effects like tachycardia and sometimes cardiac arrest. If we go in a very regulated manner, then it has no harm to continue with this Duvadelan, that is beta mimetics. But now these days, nifedipine and one more, atosivan is in the market. Atosivan is a drug which is localized up to the uterine muscle. That means there is no systemic effect. And so atosivan will be the future drug for tocolysis. And magnesium sulfate itself is a good tocolytic. If we are using for neuroprotection, Maxel, then we should not need to add tocolysis in these patients. Yeah. No need. Otherwise it will be harmful.
Tocolysis, I think atosiban is coming in a very great way, and I think next year we will plan on that also. Yeah, prices are dropping, and I think it's a very promising drug for prevention of preterm labor. So we need to discuss more about that maybe in our next CME.
While using duodenal, we are encountering with many side effects of
systemic side effects. Okay, so we conclude the session, and now I'd like to present a memento to our esteemed chairperson. So I'd like to call upon Dr. Sangeeta Singh ma'am to present a memento to Dr. Tanima ma'am. Now I would like to call upon Dr. Sujata ma'am to present a memento to Dr. Veena Singh ma'am. Dr. Ranjana ma'am. Now I would like to call upon Dr. Rachna ma'am to present a memento to Dr. Varuna Singh ma'am. Now I would like to call upon Dr. Vijayalakshmi ma'am to present a memento to our speaker, Dr. Savita Rutta ma'am. Comes the turn of our esteemed panelists. So I would like to call upon Dr. Shalini ma'am to present a memento to Dr. Gunjan ma'am. Dr. Rachna ma'am once again please present a memento to Dr. Sangeeta Rutta ma'am.
And I would like to request Shalini ma'am to present a memento to Rakhi ma'am for moderating such wonderful session. Thank you ma'am. So with this we will like to move to pediatric session, and there has been a slight change in the program due to some impending commitment in the medical college. Our speaker Dr. Rakesh Kumar sir could not be with us, but nevertheless the show must go on. So I would like to call upon the three most eminent pediatrician from ARA, Dr. JP Singh sir, Dr. JK Singh sir and Dr. Amarjit Singh sir, to come on the dais and initiate a panel discussion, and we will have a small talk by Dr. JP Singh sir, which sir has graciously agreed to. Thank you so much. Podium to start this talk and initiate the discussion.
Good evening, everybody. We all are here to witness a session on ROP. Most of the things we want to know has been told by Dr. Rop. I'll give a little bit of this topic. ROP is basically present in preterm babies, more so in less than 1500 grams and between 1500 to 280 babies. The lesser the weight of the baby, the lesser the gestational age, the more severe the disease, lesser are the chances of recovery from ROP. So basically what we practitioners do is go for oxygen therapy and other things. We have to be, take into account the age of gestation, the weight of the baby, maturity, nutritional status, and everything. So many factors, they induce the incidence of ROP. They are like low birth weight, prematurity, septicemia, jaundice, apnea, and so many things are there. So oxygen therapy is the most important thing. Hyperoxia, as known, causes it. I'll tell you some examples. When we were doing our house job in 1970 and 79, what method we had for delivering oxygen was connect a catheter to the oxygen cylinder. It was not a catheter, in fact, it was a urinary catheter cut at one end, and the other end was attached to oxygen cylinder. You manipulate the knob and get oxygen flow. There was nothing like flow, speed or concentration, no bubbled oxygen was there. I'll tell you another example. In those days, it was shown a glass box, they call it an incubator. I said, okay, incubator, fine. So once in a blue moon, there was a baby inside the incubator. So once I spotted a baby in it, I went to that room. The nursing staff was there. I asked her, how do you manage this baby? Oxygen, humidity, temperature and everything. She told me whatever she knew. And then I concluded that her knowledge of managing an incubator baby was as vague as mine. So what I see today in our neonatal units, so many things are there for oxygen therapy. We could find CPAP and PPV in the textbooks only, not in our pediatric practice. It is available now with every practitioner almost who has got a neonatal unit. So far treatment is concerned, we are pediatricians, we are concerned with oxygen therapy and taking care of other comorbidities present. This job is done by the ophthalmologist. Of course, we receive patients from Department of Obs-Gynae. What they have done is done. Good. Whatever is left, we try to improve it. This is how it goes. And we all should try to, spread this awareness about retinopathy of immaturity, so that less number of children get affected lose their lights and eyesight and so on. So this is all about it. Thank you.
Good evening all. As we are pediatrician, what is our role to prevent, to recognize and prevent ROP in premature baby and in baby more than 34 to 36 weeks with sepsis, with systemic illness like sepsis, anemia, blood transfusion, intraventricular hemorrhage, hypothermic child, twins delivery, all child less than 2 kg and less than 34 weeks to send for ROP scanning, and child between 34 to 36 weeks with systemic illness, and then to send 4 weeks after birth in child at 1.2 to 2 kg, and less than 1.2 kg and less than 28 weeks of gestation, we have to send 2 to 3 weeks of early as possible. Request to IU specialist to please come and check, recognize and check the ROP in our NICU facility. And we are a pediatrician, we can do for prevention and all. Thank you.
अच्छा, बहुत सारी बातें कह दी गई हैं आरोपी के बारे में, मुझे कुछ कहना नहीं है, मगर मैं कुछ बातें कहना चाहता हूँ कि जिस तरह से जैसे हम लोग ड्रग यूज करते हैं, ऑक्सीजन भी एक ड्रग है और उसकी भी एक टॉक्सिसिटी होती है, तो हम जब भी ऑक्सीजन यूज कर रहे हैं, खास करके प्रीमेच्योर बच्चों में 32 वीक से पहले और 1500 ग्राम पहले, तो बहुत जुडिशियली यूज करना चाहिए। उसको बहुत माने ज़्यादा हाई भी नहीं हो और बहुत लो भी नहीं हो, तो उसका जो स्टैंडर्ड मानक रखा गया है वो 91 से लेकर 93% तक ही रहना चाहिए, उससे ऊपर नहीं जाना है। रियरली कभी 95% जाए तो ठीक है, मगर बहुत सारे लोग कहते हैं कि नहीं और नीचे रखेंगे बहुत ज़्यादा फायदा होगा, और जहाँ पर देखा गया है कि 89 और 85 के बीच में जब बच्चों को ऑक्सीजन पर रखा गया है तो हम मॉर्टेलिटी रेट इज वेरी हाई। अगर we can only if you have to protect the child and I also, we have to maintain oxygen level judicially at the rate of 91 to 93%. Other things that we are not doing, we should mix when we are using CPAP, HFNC or ventilator. Certainly we have come with the ventilators and as a high frequency ventilators as SLE 4000 and 5000 I have just purchased it, but this should be also judicially used, and the oxygen level should always be maintained at the 90 to 91%. The drugs, the things that can cause prematurity, or even not even premature child, even though those child who are mature but they are on prolonged use of oxygen, they should be also checked for the ROP. And other things that we should do if the child is surviving, then we should at least take advice from the ophthalmologist, and we should contact in the at the same time also. Then we should call ophthalmologist in our NICU and should go for the ROP test. Then we are discharging the child with the prematurity who is surviving. It should be screened 1 month before after the discharge, because ROP is mostly detected in this period. Once the ROP is detected, the ophthalmologist role comes and he has to see at what zone and what severity the child is suffering from the ROP. That is, we are nowadays screening all premature child who are between the 25 to 2500 gram less. We are not one year screening the 1500 grams and 2 kg, but we are also screening for the 25,000 2500 ग्राम बच्चों के लिए भी हम लोग रेफर कर रहे हैं कि नहीं कहीं कुछ हो तो डिग्री हम लोग को उसमें नहीं फंसना। कम से कम हम तो ये सलाह जरूर देते हैं कि आप जाके करा लो भाई, क्या लगता है, जाके डॉक्टर दिनेश है, डॉक्टर अभिषेक है, जाके करा लो, जाके देख लो, जो है तो नहीं प्रॉब्लम नहीं है। लिखने में कुछ नहीं जाता है, बताने में कुछ है, और ये भी उसको बताना भी है, क्योंकि ऐसे मामला एक मेरे पास आया, मेरे पास एक 10 वर्ष का बच्चा था जिसको कि हमने आरोपी स्क्रीनिंग के लिख दिया था, प्रीमेच्योर था, चाइल्ड सर्वाइव करके ऐसा कुछ था, और उसमें लिखा था कि आरोपी एक महीना के अंदर में जरूर दिखा लेना, खुरा लेना है। वो कुछ दिन के बाद आया हमारे पास, 5 साल तक ठीक वैक्सीनेशन भी है, मैंने आया वैक्सीनेशन, डॉक्टर साहब आपको मेरा दोनों बच्चा का लाइफ खराब कर दिए थे कि आप हमको बताए नहीं, कि आपको जो हम छुट्टी किए थे इसमें आपको लिखे, नहीं आप कहीं नहीं लिखे हैं, क्योंकि आपका डिस्चार्ज स्लिप है, हाँ तब देखिए देखिए क्या पढ़िए, क्या लिखा हुआ है। तो कहा कि सॉरी गलती हो गया सर, हम कभी नहीं पढ़े ना, आपसे दोबारा कॉन्टेक्ट। तो ऐसा कभी कभी होता है कि ये सब चीज़ों से भी बचना है ना, इसलिए डायरेक्ट नाम लिख दे, बता दें, तो साफ कर दें कि नहीं आप जाइए वहाँ दिखा लीजिए, आप जरूर चेकअप कर लें, वो करा नहीं क्या उसके अलावा बस देख के लेकिन डॉक्यूमेंट होना चाहिए, डॉक्यूमेंट करना चाहिए, ठीक है। आजकल जो ये लोग अपना फिजियोथेरेपी करते हैं, जिसमें कि क्रायोथेरेपी है या मोनोक्लोनल एंटीबायोटिक जो आप यूज कर रहे हैं, जो कि आप मतलब जो है भी, तो मोनोक्लोनल एंटीबायोटिक्स का भी जैसे भेजेब बोलते हैं, बट इज कॉल्ड भेजेब, है ना, मस्कुलर यूटिलियर प्रोग्रेशन फैक्टर, हाँ, तो वो भी बहुत इंपॉर्टेंट है। ऐसे जुडिशरी जैसे तैसे आप नहीं कर सकते, क्योंकि उस भेजेब का रोल बहुत जबरदस्त है, और रोल है बच्चे के लंग के डेवलपमेंट में ब्रेन के डेवलपमेंट, इसलिए आप उसको जब भी यूज करेंगे तो आप लोग करिएगा, हम लोग क्या करना बहुत ही जुडिशरी यूज करना, एंड दैट इज बहुत कम ऐसा चांस आता है जिसको भेजेब यूज करना हो। यूजुअली क्या होता है कि जो आप लोग और कन्वेंशनल थेरेपी उसी से बहुत अच्छा हो जाता है, प्रेशर रहता है। अनदर थिंग इज जो हम लोग नहीं समझ पाते हो, नहीं पकड़ पा रहे हैं, इंटरनेशनल क्लासिफिकेशन ऑफ आरओपी, ICROP जो बोलते हैं, उसमें जो लोग स्टेजिंग करता है, स्टेज 1, स्टेज 2, स्टेज 3 एंड सीवियरिटी में प्लस और माइनस जो आप करते हैं, उसको भी हम लोग बहुत अच्छा से नहीं समझ पाते हैं। तो कभी कभी हम लोग जो पुर्जा देते हैं, जब आप लौट के आता दिखाता है तो नहीं समझ पाते, उसको भी जैसे बढ़िया से एक्सप्लेन करेंगे। ओके जी सर,
a very important point sir told that documentation is very important in ROP. If you are telling the patient, it has to be written, and if you are writing, it has to be told to the patient. It is not optional that you either tell or you either write. Because most of the litigation that happen is because of either डॉक्टर ने लिखा है पर बताया नहीं था, पेशेंट कुछ नहीं है, और आजकल जो वकील है वो भी ऐसे ही समझाते हैं, इंग्लिश में लिखा हुआ है, वो बोल देंगे कि पेशेंट को हिंदी समझ में आती थी, डॉक्टर ने तो ऐसे ही कुछ लिख दिया था, पेशेंट को समझ में नहीं आया। सो इट हैज़ टू बी रिटन इन हिंदी कि अपने बच्चों की आंखों की जांच कराएं, इतने तारीख को इतने बजे, एंड आई एम गोइंग टू शो द ROP declaration form that we have created. In that it has been everything has been documented, everything, even if they come to us and by some reason we are prolonging, we are asking them to come on a next day, what is the cause that we are telling them to come on next day, everything has to be written, documented. Otherwise ROP screening is a double-edged sword. If you are going with a good intention telling the patient, but if something happens, every blame comes on the doctor. So it is like, if you are venturing into ROP, you have to be very, very meticulous in documentation. So thank you, sir. Thank you so much for imparting us with all the wisdom about oxygen therapy. And before we conclude the session, I would like to invite Dr. P.C. Sinha sir and Dr. P. Singh sir to come and felicitate our esteemed panelists. Dr. P. Singh sir to felicitate Dr. J.P. Singh sir. Dr. P. Sinha sir to felicitate Dr. J.K. Singh sir. And Dr. With this, we conclude the pediatric session. Now, coming to the last leg of this program, the opthal session, and I would like to call upon the chairpersons, Dr. Vandana Tiwari ma'am, Dr. Ravi Ranjan sir, Dr. Amitabh Singh sir, sir, chairperson, Sheikh Kedia sir, Dr. Abhishek Singh sir, Dr. Kanhaiya Singh sir, and Dr. Amrita Rana sir. I would like to request Dr. P. Sinha sir to join as a chairperson, please. I would like to start the session, and I am Dr. Nilesh Kumar. So, I am going to talk about introduction of ROP screening protocols. So, what is ROP? ROP is the potentially blinding disease of the eye that could affect infants born 4 weeks or more preterm and have received intensive neonatal care. So, normal preterm babies, if they are managed normally, can you please switch off the lights? So normal preterms, if they have a normal course, they have not undergone any intervention, no oxygen has been given, no sepsis has been found. So mostly they survive, they have a good vision, but still they have to be screened. But the sight-threatening ROP chances are very less. But if they have any complication, they have to be screened. That is a must. So why this talk? What Rumta ma'am was telling about. It started in 2012 when the first litigation, the first punishment was awarded, and it was to a pediatrician. You can see in each and every of the cases, pediatricians have been implicated. They are the first one to be caught from 2012. But in 2015, ophthalmologists were first awarded a sentence, and you can see the amount. It is 1.8 crores. 1.8 crores of fine was slapped on pediatrician and ophthalmologist combined, citing that the patient was not informed about ROP screening. So in 2016 it happened. Negligent care of premature baby, casual and improper ROP screening by the ophthalmologist. So it was not referred and it was not screened. And the litigations that started with 5 lakhs have now reached into crore. Every ROP case is now, the litigation is in crores, because what they are telling is how much this person could have earned in their entire lifetime has to be compensated by the treating doctors. And it is not like, I don't see it far away when even gynecologists will be implicated in this, because जितने ज़्यादा लोग involved रहेंगे, वकीलों का फीस उतना बढ़ेगा. So they will implicate obstetrician that they will either preterm prevent कर सकते, कुछ भी डाल सकते हैं. They can say that preterm could have been prevented, or the parents could have been informed that if preterm delivery is going to happen, the child could have ROP and hearing impairment and all. Anything they can say, they can implicate, and the judges are not well read enough, they are not informed enough, and they can slap the fine. So we have to be very careful. So what are the risk factors? This baby is the risk factor for all of us, but what the baby is having risk for developing ROP? Preterm babies who had got supplemental oxygen, had got sepsis, and had poor weight gain. These 4 factors, if it is there, definitely it has to be sent to ROP screening. Even if not, it has to be sent, but these 4 things, they have to be sent. So prevention of ROP is an interdisciplinary approach, and this is the aim of today's conclave. We have to prevent preterm birth. As long as possible, we have to prolong the pregnancy. In situ transfer of threatened preterm delivery to a health facility with NICU, as Rakhi ma'am was telling during her moderation. Antenatal steroids for threatened preterm, so the lungs are mature and the oxygen requirement is very less. And prevent ROP among preterm infant by quality neonatal care. Do not delay the NICU admission. And then everything in delivery room, there is gentle resuscitation. I think that the attendees and the panelists are more competent enough than me to explain. The secondary prevention comes where our role comes. There is early detection of site-threatening ROP, urgent treatment of site-threatening ROP, and follow-up of treated infants. And in ARA only there are 3 centers that are doing ROP screening, so there is no dearth of ROP screening facilities in Lakshmi Netralaya, Rudraksh Netralaya, and our center. ROP screening is available. Please, please, please avail it. It is a must that every patient, every child that is preterm and having risk factor should be screened. And if there is something that is happening, tertiary prevention can be taken care of. So, screening for site-threatening ROP, about 15% of the babies with risk factor develop very severe ROP, risking the site, emerging as the leading cause of avoidable childhood blindness. It is not unavoidable, it can be easily avoided. If detected early, sight loss can be prevented by use of lasers and anti-VEGF, that device I will be talking about, or a combination of both. All infants admitted to NICU with following criteria needs examination by fundoscopy, that are 34 weeks of less of gestation, 2000 grams or less at birth, infant born more than 34 weeks but have some risk factor, that is cardiorespiratory support, prolonged oxygen requirement, respiratory distress syndrome, chronic lung disease, fetal hemorrhage, blood transfusion, sepsis, exchange transfusion, intraventricular hemorrhage, apnea, and poor postnatal weight gain. Anything of these, even after 34-week baby is not preterm, still it requires an ROP screening, at least a baseline screening. And other preterm infant, based on the discretion of pediatrician or neonatologist, if you feel that the baby is sick, it has to undergo a screening. When to do? I think it has been told multiple times. If the child is in NICU, it has to be 30 days of life. If the patient is being discharged before 30 days, at the day of discharge or the next day, the baby has to be screened at the ophthalmologist clinic. Who can perform? If it is going to be indirect ophthalmoscopy, a trained ophthalmologist. And a trained ophthalmologist doesn't need to be a retina surgeon. Anybody who is doing an indirect ophthalmoscopy, who can see the retina, can actually screen for ROP. They are not, even if they are not, they don't know how to treat, they can send it to the retina person if the child is having ROP. But anybody who can see the retina can do the ROP screening. Fundus imaging is a very important tool because there are a lot more, the requirement of ROP screening is a lot more than what an ophthalmologist can cater to. And that's why government has allowed fundus imaging, that is wide field imaging, by a trained and competent personnel. It doesn't have to be a medico, it can be any personnel who has been trained to take an image, can do the ROP screening either at the clinic or at the NICU and send the photo to a retina specialist, and they can classify what is ROP and the child needs to be brought for further examination. Where to perform? In an ICU if the baby is not discharged at 30th day, in ophthalmologist clinic if the baby is discharged and stable. If the baby is unstable, it has to be done at pediatrician's clinic. What is follow-up schedule? If the mature, if we can see that the, sorry. HDMI. So if you can see that the baby is having mature blood vessels, or if the baby was having some degree of ROP that has started to regress, no follow-up is required. Still, it is my protocol to see the baby after 4 weeks. I have written in all of the 56 babies that I have seen in last year. Not one of them has come at 4 weeks to get it checked again, but still it has to be written that the follow-up has to be done 4 weeks just to be safe side if the ROP that has regressed starts again. ROP present in one or both eye, the baby has to be screened in 1 to 2 weeks depending on what stage it is, and urgent treatment within 48 hours if the patient is having sight-threatening ROP. Recommended age of last follow-up is 7 years. It's not that 1 time or 2 times we just see and leave, because the patient will have multiple complications going forward. They will have refractive errors, and there are chances of RT developing later also. So better to have at least 7 years of follow-up. Ideally is lifetime. One case has been presented in our conference where the baby was at, I think, 16 or 17 years, developed an RD, and then the doctor was sued that we didn't tell us that the lifetime follow-up was required. They read it somewhere and they sued the doctor. Even after following it for I think 10 or 12 years, still the cases can happen. So coming to what sir was telling about classification of ROP, that is international classification of ROP, version 3. So there are 3 zones depending as central we are, the more vision is there in retina. So zone 1 is having the most vision, and that is measured from macular to optic disc. We double it, and that is the circle that forms is zone 1. Zone 2 is outside that, reaching to the nasal side. We draw a circle, that is zone 2, and whatever left on the temporal side is zone 3. Zone 3 is the least sensitive to light, zone 2 is intermediate, and zone 1 is the most sensitive one. So in that posterior zone is also, posterior zone 2 is what is considered the disease is there, it is also considered aggressive. So the stages of ROP is active stage is, it is very simple. If a line, the blood vessels are not crossing, they form a line first. Line is kind of a bridge that is dividing both the part, the vascular part and avascular part. That is stage 1. Stage 2 is when that line starts to have a second dimension. It starts proliferating from that. That is a natural response. If the avascular retina is there, the ROP proliferation kind of thing starts, RP proliferation kind of thing starts, and it forms a ridge. And if the ridge starts to have flat neovascularization, it is stage 3. Stage 3 neovascularization shows that the VEGF production is quite high, and the new vessels are being, the aberrant vessels are being formed. And then we have stage 4, that is the stage of retinal detachment. When it is subtotal with macula on, it is 4A. When the macula also goes off, it is stage 4B. And stage 5 is complete RD, like no part of the retina is attached to the choroid, and that is the most devastating stage, and it is very, very, very rare, though our surgeons in Bihar are competent enough to operate on stage 5 and save some sight. It is very rare, and not the outcome are not that good. So the aggressive disease is pre-plus disease where the vessels are dilated, and when the vessels are dilated and becomes tortuous, it is plus disease. So these are the 2 aggressive forms of ROP. So it can be in any zone and any stage. It can be plus, pre-plus also. So ROP screenings initiative are also taken by government. There is an ROP task force that has been formed, but the government implementation is not that good. At least in North India, South India, a very good implementation is happening. There is a ROP van that goes around in all the district hospitals and in ICUs. They do the ROP screening and send it to the central center. But in Bihar, in North India in general, it is not happening. So what is mobile ROP screening? That is a red cam. It is a portable fundus wide field image that is dedicated only for ROP. It can be done by a trained personnel and reported by ROP expert. It is very fast, efficient, and can be done at an ICU. Even if an ICU is in periphery, as Devices Center is having one ROP screening, and they have graciously agreed that if any NICU in Ara or Bhojpur, they want to do ROP screening at NICU, they can pool the patient in one day. They can once a week or twice a week, they can call the camera in here. They will do the ROP screening. The photos can be sent to the center. The child can be screened at NICU level itself. So coming to ultra-wide field imaging that can happen at hospital, the ophthalmologist clinic. This is a facility that we are going to acquire probably by mid-November, and we will have it functional in December. That is ultra-wide field imaging of children to show the patient what the disease actually is, because if the child or the parent, if they can see it, they will agree for treatment and how important the treatment is. So this is how the imaging is done. This is a study that was done at LVPI. It has not been replicated anywhere else. We are trying to adopt. We hope we will succeed in doing this. The child is, speculum is put as we do in ROP screening, and the child is held in the flight position, and the chin support is given by hand by one of the trained personnel, and the next person takes the image. It takes less than a second to take the image, and entire retina is seen. So it is less traumatic for the child because the child is not cooperative. What we have to do is to use a pen kind of thing, a metal pen kind of thing, and rotate the eye to see all the structure. With this, a single click, at least we can see beyond zone 2. So we are pretty sure. We also are pretty sure that we are not missing anything, and the child also can be. The parents can also be taught, and most important of it is it will be documented. Nobody can claim that this was a disease, you missed it. It is documented what the status is, and this is the during demo phase. This is the image that we could get. This is not from ROP baby. It is from a normal patient, but this is the clarity that we get. So we are not going to miss anything in this. So this is the ROP's equation form that I was talking about. This is the last slide. Here we have gestational age at delivery, what is corrected gestational age today, birth weight, current weight, nature of delivery, resuscitation if required. Please, all details has to be mentioned. Child visited at our clinic, what time they visited, that is also mentioned, because if they come late in night and somebody is not there to see, then at least we can have that when the patient came and when he or she was screened. There are maternal risk factor, the perinatal risk factor, and the use of oxygen. Everything can be filled in this so that the ophthalmologist can know what has happened and how important it is to see it very meticulously. And if, because of any reason, if the child is not screened on the day of presentation, what was the cause, and we will write a date next visit when the patient is going to come. So these all documentation is very required. Otherwise, if we just screen and write something, we might miss and a litigation can happen. So ROP is all about saving sight and saving litigation. Thank you so much. So we'll have a discussion at the end of all the talks, and I would like to call upon my guru now, ROP management with anti-VEGS and ages by Dr. Prakash Tiwari sir. He is the person who has initiated ROP screening in Bihar. Tehsil, jahan pe bhi they called, he used to go in his car late at night, anytime. I think somebody told me that there was a confrontation with a gunda or something during one of his visits. Still he persisted and he performed ROP. So the passion for ROP screening came from him, and I would like now like to hand over the mic to sir for presentation. Thank you.
Managing such a wonderful meeting, and good evening all the respected seniors. I am really very obliged to be here among you, and I just this ROP disease is a modern era disease, as we all know. The disease was first detected in around 1937, and it was used to be called as retrolental hypoplasia. And the reason found was excessive use of oxygen, and when the cause was recognized, the oxygen use was cut down, and the disease disappeared from all around the world. But again the disease bounced back. When what happened? The term babies which used to be given oxygen are no longer getting oxygen, but all those preterm babies who were very small and they have started surviving, then again they needed oxygen, and the disease came back again in the decade of 1960s. So that was second epidemic of ROP, and currently the world is in the third epidemic of ROP.
as Rungta ma'am was very rightly was saying that a lot of patients are undergoing IVF delivery for infertility and all problems. In developed cities, this disease is becoming more and more common because due to these professional challenges and many a times the husband wife not staying together, they are under stress and they have very less time and they want quick babies, and even normal appearing couples are opting for IVF and all. In Hyderabad, Subhadra Jalaji ma'am was saying that there is a huge surge of ROP cases. Why? Because majority of the people are working in Gulf countries, so they will take a leave from their job for 6 months, 8 months. They will come to India, they want to marry and have child also during those 6 months. And if in 1 or 2 months after marriage they are not having, expecting a wife is not conceived, then they are going for IVF. And getting twins and triplets and all those babies are going to an ICU and developing ROP. So all these things, this stress and lifestyle and all these challenges are increasing the number of ROP babies day by day. As an ophthalmologist, we can't prevent these preterm babies or ROP happening in those babies, but at least we can detect them and we can treat them if required on time to save them and let them see this wonderful world in the with their beautiful eyes. So laser is currently the gold standard treatment. ये ऐसी बंद हो जाएगा, ठंडा लग रहा है. So currently the laser remains the gold standard treatment of ROP, and this treatment has been established onward the decades of 1990 when indirect laser ophthalmoscope delivery system was invented. Laser was invented in the decade of 1960 and 70, but that was slit lamp laser in which the patient need to put the chain and then we put a lens and then fire the laser. So that system was not possible to do ROP laser in those cases. So during those era, cryo was the treatment, cryotherapy was the treatment for that ROP. But cryo induces lot of inflammation and swelling, and it was causing lot of high myopia induction in the kids. So later on, when the laser indirect delivery system was invented, then the treatment shifted to laser from cryo. Cryo treats on the same principle, but the inflammation is very less and patient doesn't need a GA or anything, and you can see that we are delivering laser to those ROP babies. So what is the indication of treatment? All type 1 babies, all babies with type 1 ROP needs treatment with the laser or injection, whatever is the indication. So what is type 1 ROP? Any zone 1, stage 1 or 2 with plus, or stage 3 without plus. In nutshell, if we want to understand in a very simplistic way, we must remember that if there is plus, it needs most likely treatment. Because the only one indication in which we do not treat with plus is zone 2 stage 1 plus, but generally we never see zone 2 stage 1 with plus. If it is plus, then generally the disease is stage 2 or beyond. So for all practical purpose, all plus needs to be treated. Only one exception of treatment without plus is zone 1 stage 3 without plus we need to treat. But again, if the disease is stage 3 in zone 1, it is such a severe disease that definitely it will have plus. So most likely and practically only one thing we need to remember is plus disease. If there is a plus disease, it must be screened or seen by a retina colleague, and most likely it needs treatment. And detecting plus disease is very simple. Any ophthalmologist who is able to see the fundus with indirect ophthalmoscope, or for that matter even direct ophthalmoscope, we need to just dilate the pupil, fix the head of the baby and open the lids by putting a small speculum, and we can just see the center of the disc, and if there are dilated tortuous vessels, it means the baby is having treatable ROP. We need to treat that baby. So that one simple point, because the disease is very complicated, this stage, that stage, AP ROP, this ROP, that, we should not remember all those things. As a general practitioner or consultant, we must remember this very important point, plus disease. If there is plus, it needs treatment. A lot of publication and work has been done. And this paper published from our own teachers, Subhadra ma'am, Dr. Azad, they published that ROP can be done under topical anesthesia. Before that, or even in current era, in Western country, they are doing treatment by under general anesthesia, putting intubating the baby, giving full GA and then treating with laser. But that creates another challenge for our country, which is still a developing country. And that highly trained anesthetist is not available in every nooks and corner of the country. All those anesthetists who can give GA to 500 gram baby, 800 gram baby, they can intubate and give us the baby for a laser. We can't afford that much. So this topical laser treatment has been developed by our own teachers and it works well. And we have done n number of lasers under topical and it doesn't cause any problem to the baby. Again, staff holds the head, baby is wrapped in a proper cloth, a sliced cloth. The hand and everything is wrapped in the cloth and just head is being held by the staff and we can do laser treatment under topical, and that is a very simple treatment which saves lot of eye. This is the same thing which I was explaining. This all zone and everything has been explained nicely by Dr. Nilesh. And this is one case of classic ROP where we can see there is a ridge. We can see there is a ridge, and this is stage 2 and somewhere neovascularization is there, so stage 3. So in ROP, even at one single point or 1 clock hour, if the stage is 3 and rest everywhere it is stage 2, we have to report it as the worst stage. Like stage 3, even in 1 clock hour, it is stage 3 for everywhere. If it is stage 2 in all clock hour, but even at one point there is neovascularization, then we should report it as stage 3, or like that in stage 1 everywhere, and at one point stage 2, then it is stage 2 everywhere. So worst stage is reported, and again this is classic stage 3 where there is a ridge and this ridge is getting elevated and coming into the vitreous cavity, and these kind of cases must be treated immediately. And these are also stage 3, proper stage 3 cases. These all vessels are dilated, tortuous, not normal vessels. Here we can see the branching in fan separate branching of the vessels, and this is the ridge which is getting elevated. And if we do not treat, then such kind of baby in generally 5 to 7 days they will go into stage 4, that is traction detachment of the retina. Again, this is we can see evolving stage 4 ROP. Here the stage 3 is now becoming, it is pulling the adjoining retina and it is in the process of getting detached. So it is still a stage 3, but sometimes we call it for our practical or to inform the gravity of the disease as evolving stage 4 to the parents. And this is the immediate post laser. The baby was having the treatable ROP and we did laser, and this image was taken immediately post laser. We can see all these faint yellow spots as laser spot. And what we have to do in laser, we have to paint all the vascular retina with the laser mark, confluent or near confluent laser bonds. That is, laser bonds should not be spaced apart as we do in adult. Whenever we are doing laser treatment, we are giving one spot size distance between 2 spots. But that is not the case in ROP. This is regressed ROP with old scars, laser scars. We have done laser and the ROP is regressed. We can see some of the skip areas. We have to see in the follow-up all these things. If a ROP has regressed and there are few skip area, we can leave them. But suppose ROP is not regressing, the tortuosity hasn't gone down and the vessels are still appears angry, then we can do additional lasers. Like after a week or so, if we see, then we can do fill-in laser to all these skip areas, and then the ROP start regressing. But once it is regressed, then there is no need to do additional laser treatment. These are some of the aggressive ROP which we see sometime. These are actually the mixed kind of retinopathy. The baby was extremely sick. He received multiple life-saving drugs and was on ventilator, received a huge amount of oxygen and developed bad ROP. There are hardly any vessels, all these closed vessels. This is the macula, there is exudative retinal detachment in the center, and we see here a large amount of hemorrhagic clump Here also hemorrhagic clump, and this was very angry looking, scary looking ROP. We decided to inject it with a anti-VEGF monoclonal antibody ranibizumab, and we can see this the pattern is on the site of regression, and after doing laser this disease is regressed. But ROP is not a single problem to all these preterm baby. That baby is now 6 years old, he is still following me, but the child has developed cerebral palsy and under treatment for that. So it is a sad state of affair, but at least parents are grateful and happy that the child is seeing that. So we haven't added another problem to the child, and somehow the child is getting managed by a pediatric neurologist. So the protocol is under topical or general anesthesia. Diode laser 810 nanometer is preferred. This is also again being challenged by Indian surgeons, and we are doing with green laser and finding it very good outcome with less inflammation. So now the whole world is following India and switching back to green laser. Power is around 150 to 300 milliwatt, duration is 100 ms. And interval depends on the skill and experience of the surgeon. If we, in earlier days, we used to keep 300 millisecond interval, that is between two spots, there should be a pause of 300 millisecond. And as we become experienced, we can go up to as low as 50 millisecond interval to finish off the laser faster. So number of spots sufficient to ablate whole retina. In a single session, we should try to finish off the laser, but if the baby is sick and not able to withstand the stress of the laser, then we can split into 2 or 3 sittings also. I hope this video plays. Yeah, this is a laser being done. The both videos of laser being done. One in our operation theater. This is being done in our operation theater. The baby was discharged and the laser is being done, and this baby is just being held by our OT assistant staff, and no anesthesia has been given. This is the laser machine. This is the laser indirect ophthalmoscope, and I am holding a 20 diopter lens, and this is indenter and doing laser. This baby was too sick to come to our clinic, and so we went into the NICU to treat the baby, and this laser is being done in a pediatrician's NICU. The baby is still under support, and since the baby was more than 30 days, we did a screening and found a treatable ROP, and we did laser treatment. Signs of regression: media starts becoming clear, pupil dilates fully, no new vessels in the iris. One more important point I forget to mention: non-dilating pupil is a sign of ROP, a definite sign of ROP, treatable ROP, aggressive ROP. This is such a strong sign of ROP that the staff in the OPD who are showing me ROP cases for last 10 years, even they detect. 3-4 बार दवा डालेगा, डायलेटिंग बोलेगा, सर लगता है इसको आरओपी है, पुतली फैल नहीं रहा है. They have become so expert in that. So that is a very important sign. If you are putting properly dilating drops by opening both the lids and the drop goes inside the eye, and after 3 drops of 10 minutes interval, if the eye is not dilating, that is a definite sign of ROP. And that is a sign of regression also. If we have done laser and now the pupil starts dilating easily, the media becomes clear, the view is good, it means the laser has worked and the ROP is regressing. Add laser required, as I told that all the skip areas, if it is not regressing. Laser ablation has written complication in the textbook, but I have never seen all these complications. Apnea can happen to any baby, so we take care that an statist is there standby to take care of all those things. Corneal haze we do see rarely, and in those cases we wait till the cornea clears and we can do a repeat laser. Subconjunctival hemorrhage is not a serious complication. Anterior segment ischemia, necrosis I have never seen, cataract I have never seen, hypotony I have never seen, phthisis I have never seen. Vitreous hemorrhage minimal can happen, especially in advanced cases of ROP where the baby has come to us at a later stage. In those cases, due to diseases can happen, it generally doesn't happen due to laser. Complications to the surgeon, that can happen, the neck pain, shoulder pain, back pain, all these things can happen to all the retina colleagues, as we have experienced in our life. And Injection, as I was telling about this case, that hybrid treatment we are doing. Now lot of anti-VEGF are available in the market, and why anti-VEGF is working in ROP? The disease is being driven by VEGF. There is hypoxia, ischemia leading to increased load of vascular endothelial growth factor in the eye. That creates all the problem: proliferation, neovascularization, traction development, ridge development. So we have to halt that VEGF. Wherever the laser is not possible, or there is a huge area of a vascular retina, or even macula is not formed or vascularized, then we cannot do laser in those cases. So we can inject anti-VEGF, the VEGF load comes down, and the baby develops a complete regression of ROP with vascularization of some sort of retina. And generally after 20 to 30 days, whatever part remains avascular, we do laser treatment to those parts, and it works wonderfully. Lot of study is being done, and all the study have shown efficacy of all kind of anti-VEGF. All the anti-VEGF available in the market works wonderfully. Currently 3 anti-VEGF have become US FDA approved. One is original innovator Eccentrix, marketed by Novartis. Another one is our own homegrown, that Razumab is being marketed by this Intas people, and currently the IDEA also got approved for ROP, that is aflibercept, marketed by Roche. So these 3 are approved drugs to be used in ROP, but we have personally experienced use of all anti-VEGF, and it works very well, be it Avastin or Vizumab of Cipla or Reliance or whatever we have used, and we have found complete regression. How to give anti-VEGF? This is also being done under topical. Just paint the baby and put a speculum and just see under a microscope, measure 1.5 millimeter from the limbus, and just take a 30 gauge needle and load the drug and go inside the eye and just push the injection. We generally inject 0.02 ml of drug inside the eye. So the amount of the drug is very small, extremely tiny, but that 2-3 drops, just 2-3 drops goes inside the eye, but that works as a magic bullet inside the eye, and it just clears the ROP like anything. The only thing is that after 1 month the effect of drug is gone, and majority of the baby starts developing ROP again. When post injection ROP starts reappearing, then we do not wait for stage 2 or 3 or plus, nothing. Once injection given, whatever stage of ROP starts coming, even if it demarcation line or stage 1 or whatever, immediately laser that eye. We do not wait for full blown ROP. Medico-legal status of injection I have already discussed. So in conclusion, laser remains the gold standard treatment for ROP. Anti-VEGF works wonder in ROP, but needs long-term follow-up. In aggressive ROP, results of laser is not good, and injection is the better option. Injection are also being used as adjunct therapy to pre-op and post-op of advanced stage 4. I am doing majority of the baby who come on time, they do not need surgery, they do not develop stage 4 or 5, but unfortunately if there is lack of timely referral or sometime reluctance by parents, the baby is coming late, then it develops a stage 4 and 5, and those babies need surgery, and surgery is a bit challenging and result is also poor, needs lot of patience from the surgeon side also. Fortunately in our center, Dr. Ratnesh Ranjan is there. He was having huge experience of operating such babies in Arvind, Coimbatore, and here also he has operated lot of babies, and fortunately we have got very good outcome in stage 4A and 4B. Stage 5, the result remains poor everywhere in the world, be it Patna or Delhi or Chennai or Hyderabad or anywhere in the world. So our aim is to screen on time, detect the disease on time, treat it with laser and injection, prevent surgery. But if at all the baby develops that stage 4 and 5, we cannot leave them to become blind. We should try in 4 or 5 cases also, and that will be talked upon by my next speaker. So Nilesh, for you, thank you so much for that.
Thank you, sir, for such a wonderful talk, and I think everybody has now perceived that this is a treatable disease. It is not as scary as it sounds if screened on time, treated on time. But if the time has gone, the delay has happened and the RD has happened, then role of advisor comes. So welcome, sir, to tell us about surgical treatment of ROP.
Good evening, everyone. So basically, I am the last barrier between you and your dinner. So I'll try to finish it off quickly. So the role of surgical management in ROP is limited to the only late stages of ROP, which is stage 4 ROP and stage 5 ROP. In stage 4 ROP, we categorize the disease into stage 4A, where there is subretinal detachment but not involving the macula. So in such cases, the first line of treatment is laser itself, as told by Dr. Tiwari sir. But in such cases, if disease continues to progress and traction starts threatening the macula, then we need to consider for surgical management in those cases also. But if child is presenting with stage 4B ROP, the surgery becomes the first line of treatment. So stage 4 could be acute stage where disease is still evolving. In such cases, the prognosis is slightly better. But if the presentation is very late and the stage 4B ROP has already established retinal fold, then in such cases, the prognosis becomes slightly poor. Coming to stage 5 ROP. So we all know that stage 5 ROP carries extremely poor prognosis. So before considering the surgical treatment, we need to consider various factors which include stage of presentation, configuration of retinal detachment seen on ultrasonography, and most importantly, willingness of the parents for the surgery. So as described by Dr. Nilesh, the ICROP3 has subcategorized stage 5 ROP into 5A, B and C. So in 5A ROP, we can see the optic disc with indirect ophthalmoscope. So it means the retinal detachment will have an open funnel configuration. Among all these three subcategories, the stage 5A carries the best prognosis following surgery. In stage 5B, optic disc is not seen, and that could be either because of the presence of fibroplastic membrane behind the lens, or it could be because of closed funnel of retinal detachment. While in stage C, stage 5 ROP presents with anterior segment changes like shallow AC, shallow anterior chamber, or corneal opacity, and these features are suggestive of closed funnel detachment. So this is the stage where worst prognosis will be there. Whenever we are not able to see or the posterior segment view is obscured, we have to go for ultrasonography, and we can make out the various configuration of retinal detachment, which is described as open-open, open-closed, closed-open, or closed-closed. So this is the open-open configuration which will be having better prognosis in case of stage 5 ROP. So next important point is when to do, because ROP is a bilateral disease. It affects both the eyes simultaneously. And in ophthalmology, we do sequential surgery for two eyes. Whenever we do cataract surgery or any other intraocular intervention, we have to go for sequential procedure. Like one eye is operated and after a few weeks only we go for other eye. But that we cannot do in case of ROP because it's a rapidly progressive disease. If you operate in one eye and other eye has to be operated after some time, by that time we might lose the vision in that eye. And also that doing sequential surgery will expose the baby to the bad effects of general anesthesia at very short interval. So now in literature it's already proven that simultaneous bilateral surgery can be performed in ROP, babies having bilateral ROPs, and it reduces the harmful effects of general anesthesia as well as avoids the progression of disease in fellow eye. The next question is how to intervene surgically. So basically we have two options. The first is vitrectomy along with lensectomy. So this surgery is performed in cases of advanced stage 4B ROP where there is inadequate surgical space between lens and retina. So in late stages of ROP, the retina will be anteriorly pulled up towards the lens, so the surgical space becomes very narrow. So if it's extremely narrow, we have to sacrifice the lens. And most of the cases of stage 5 ROP will need lensectomy also. So this is a baby who was having a stage 5 ROP. Here you can see the lens, and behind that you can see the retina, which is totally lifted and coming up behind the lens. So this is short video of the surgery. So here lensectomy is being performed. We use the vitreous cutter itself to perform the lensectomy. Infusion line is there to maintain the intraocular pressure during surgery. And now scissor is being to cut the fibrous membrane present behind the lens. Once lens was sacrificed, the membrane is being removed. This is very fast forwarded video. The surgery is actually, surgeon has to be very patient and cautious, avoiding any injury to the retina, because once retina is injured or if any break happens or hemorrhage starts, then we lose the eye. Now you can see the retina. So once significant amount of membrane is removed, we do limited vitrectomy, whatever surgical space is available. And then finally residual membrane was removed and eye was closed after injecting air inside eye. So coming to the outcome, in stage 5 ROP the outcome is extremely poor. We describe the success in two ways, anatomic success and functional success. So anatomic success is described as just the reattachment of retina which was lifted. If it is falling back to its place, then we call it anatomically success. And that raise itself is 13 to 40%. Most of the cases it's around 20 to 25%. So, but that is success for us. That success is not going to affect vision of the baby. It doesn't matter for the attender how much anatomically successful surgery is. What matters for them is the functional success of the surgery. And even if surgery is successful in terms of anatomy, the functionally patient will get hardly perception of light or hand movement or some form of form recognition or at max ambulatory vision. So this is where I told you the most important point is the willingness of the parents for the surgery. In normal cases where ROP can be treated with laser, we have to stress the attendant many times that it is the time you should go for the treatment, and attenders will be saying, Dr. Sahab, itna chota bachcha hai, laser kyun karna? They are not willing to get baby screened at that stage ki sir itne chote bachche ko kyun dikhana hi hai. So basically for laser we have to stress them to go for laser, but in case of surgery we just tell them this is the situation, this is the prognosis, whatever option we have is the surgery. We don't know how much success we are going to have, what will be the visual potential after surgery, and after understanding that, if they force us to go for surgery, aap karo surgery, hame koi fark nahi padta, we just want to take an attempt, so in that case only we go for surgery. So the next surgery is lens sparing vitrectomy. So lens sparing vitrectomy, where vitrectomy is performed sparing the lens, so we can safeguard the lens. This surgery is performed in cases of macula threatening progressive stage 4 AROP, early stages of 4 BROP, and stage 5 ROP if there is enough surgical space present behind the lens. So since there are various factors which makes vitrectomy different from the conventional vitrectomy what we do in adult eye, so we need to modify various steps of vitrectomy while doing surgery for ROP. So this is the fundus picture of a 3 or 3.5-year-old boy. The left eye was having a spontaneously regressed ROP. So no treatment was given, the ROP started coming and then slowly it regressed on its own. But the right eye was having a stage 4 BROP with established retinal fold. So basically what you are seeing is like this is the falciform fold along the inferotemporal arcade. Here there was focal traction and one more focal traction was here. And the fovea was not seen because it was covered behind this fibrous band and vitreous condensation. So for this eye surgery was performed. This is a surgical video. So here the vitrectomy is being performed. Now the tractional bands are being removed slowly. This band was dissected. There is tractional band is there, which we need to cut. So now this band is dissected. So for this area, the traction is gone. Now slowly we trim the membrane present over the retinal fold. And unlike adult eye, we don't need to go for complete vitrectomy. We just have to do core vitrectomy and remove all the tractional band. That much only is needed actually for ROP eyes. So this is the fundus picture post surgery, at 1 week post surgery, and you can see that the traction is settling down. The fovea is nicely exposed also. This eye of the baby is going to have some good amount of vision. This fold will persist like this, and this area is the area of retinoschisis. And this is what we were having pre-op. So you can make out the difference after surgery. So this is another baby who was diagnosed with 4A ROP, and adequate laser was performed. So you can see the laser scar here. But despite the laser, the traction continued to progress and started pulling the macula. So now it was becoming stage 4B. So it was evolving from stage 4A to 4B despite good adequate laser treatment. This is the left eye of same baby. Here you can see the laser marks, some vitreous hemorrhage and the traction over the macula. And here you can see the dragging of temporal vessels also. Vessels are also being pulled up towards temporal side. So this is surgical video for the right eye actually. So here that tractional band from disc to the base is being dissected. As usual, we do limited core vitrectomy. This tractional band from this arcade to this arcade is being cut here. In neonatal eyes, if there is some vitreous hemorrhage, we don't need to remove that hemorrhage completely because it will go on its own. So the principle of surgery or the main aim of the surgery is just to remove all the tractions, just to relieve all the tractions. So this is the pre-op fundus picture for right eye, and this you can see 1 week post-op fundus picture where the traction has gone, the macula has fallen back in its place, some residual membrane is there, and this is fundus picture at 1 year follow-up where retina is looking almost normal. Now this is the fundus picture of left eye, and this is 1 week post-op. Here you can see a bit more residual band was there, but with time, since the traction was relieved over the time, this detachment has settled down, the dragging has stopped there itself. And recently this baby came for 2-year follow-up. So now the surgery was performed 2 years back, and the baby came for 2-year follow-up recently. We tried to capture this fundus picture was taken with red cam, which is supposed to be used for this infant eye. But we tried to capture the fundus picture with routine fundus camera, what we use for adult eye, and obviously we could not because baby was not cooperating. But what we could capture is this. So he has grown up now. You can see his smiling face. He's having crystal clear lens. If I could show you the fundus picture, it will be just like laser retina. You can't even think about surgery was performed in these eyes. And he's having refractive error of only -1.5 diopter. One thing with the ROP surgery is like in adult eye after cataract surgery or something, patient will experience the improvement in vision, clarity in vision, and patient can tell you like now I'm having improvement in my vision. But babies will not tell that whether they are having improvement or not. So the result, what patient has actually gained from the surgery, we will come to know only after 3 or 4 years when they will start reading or understanding other things. So sometimes it's difficult to explain to the parents like whether baby is having improvement, functional improvement or not. So that is one of the challenges we face in following surgery for ROP. So to conclude, ideally we should not be getting advanced ROP stages requiring surgical intervention if we have a robust screening system and if we can increase the awareness level among the general public. If we get such cases, we have to be equally capable to offer a surgical management, and a timely surgical intervention with proper technical modification would result in best possible outcomes even in advanced cases. Thank you.
Thank you so much, sir, for showing us wonderful videos and to show that smiling child that makes everything worthwhile what we are doing for. In view of shortage of time, we will have discussion over dinner. Otherwise, the husbands are left for peace tomorrow. The wives will leave before that. We will have we'll move towards dinner. We will just have a felicitation, small felicitation before we move. I would like to call upon Jivesh sir to felicitate Dr. Satyaprakash Tiwari sir and Dr. Ratnesh sir. Ratnesh sir. I would like to call upon Dr. Roshan sir, SR from AIMS, who is retina person and has come all the way from Patna to attend this session. Thank you for coming, sir, and I would like you to felicitate our chairpersons, Vandana ma'am, Ravi Ranjan sir, and Amitabh sir. I will request Dr. J.P. Singh sir and Ramarjeet sir to please come forward and felicitate our chairpersons. Sorry, panelists. Yes, sir. J.P. Singh sir, to Abhishek Kedia sir. Sir. Amari sir to felicitate Amarendra Anand sir. to felicitate Dr. Kanya sir. Amarjit sir. दो आदमी और हैं अभी. To felicitate Dr. Kanya sir. And Abhishek Singh sir. सर एक हमको भी देके देंगे सर.
This is doing wonderful work at RA. He has been there in RA from last 1.5 years, and we are hopeful that we'll be doing all such kind of CMEs in association with various bodies. And I would just at the end like to say that रुंगला मैम की स्लाइड थी 30 दिन रोशनी के. 30 दिन is very important, and ARA, as we all know, all these specialties are very developed here, and so ophthalmology is also developed, and we would like you to refer these babies whom we can prevent their sight, and we definitely do good work. We have been doing this, and just एक ही रिक्वेस्ट है 30 दिन रोशनी के, उनकी रोशनी जरूर बचाएं प्लीज. इन बेबीज को स्क्रीनिंग पे जरूर भेजें.
Also thanks to both by Dr. Sonali Singh before we proceed further.
I would like to thank IMA President Dr. Kumar Jitendra sir, IMA Secretary Dr. Shalini ma'am, eminent gynecologist Dr. Vijay Lakshmi ma'am, senior most ophthalmologist Dr. PC Sinha sir for inaugurating the program. The program would not have been successful without enriching talks from Dr. Savita Runta ma'am, Dr. JP Singh sir, Dr. JK Singh sir, Dr. Amarjit sir, Dr. Satya Prakash Tiwari sir, Dr. Ratnesh Ranjan sir. I would like to express my heartfelt gratitude towards them. The obstetric session was moderated by Dr. Rakhi Agarwal ma'am, and we thank you ma'am for doing that wonderfully. It was a privilege to have the who's who of obstetrics, pediatrics and ophthalmology as chairpersons and panelists, and we are very grateful for their presence and participation. The biggest round of applause should be for everyone who attended the session and made it a grand success. This program was co-hosted by Drishti Kunj Eye Hospital under the aegis of Shahabad Ophthalmological Society and Bhojpur Obstetrics and Gynecology Society, and we are eternally grateful for the constant guidance and support. A big thanks to Intas Pharmaceutical and Mr. Amit Singh ji for sponsoring the entire program. Hari ji from Anita Enterprises and his team, who came down from Patna to provide us with excellent audio-visual aids, deserve a big thanks for a job well done. We are also thankful to the management of Regal Resort for providing us with a great venue, and I would like to invite you all to awesome food that awaits us. Thank you all.